Okay, so it looks like this is recording. So I'm going to do share screen. Urinary system. Okay, so hopefully that's up. So this is urinary system, and I'll put this up on YouTube. So here's a kidney. It's not a very good looking kidney, but it's a kidney, and we'll learn the parts. But first, let's learn a little bit about the functions. Micturition, that's just going to the bathroom, removal of metabolic waste through that process. Um, the kidney can help regulate ionic concentrations in the plasma by controlling the amount lost in urine, for example, potassium or sodium or whatever. pH balance, it can help with that. You know, it's more of a slow process compared to the buffers in your blood or your respiration, but it can remove ammonia and help balance pH in that way. Regulates blood pressure, blood volume slash pressure by controlling the amount of urine produced. So yeah, say your blood pressure is a little high. Basically, there's a regulatory mechanism, and it'll make you go to the bathroom a little more and reduce your blood volume, and thereby hopefully bringing your blood pressure down. Stimulates erythrocyte production. How does it do that? There's some cells in there, and we'll get to those later. But basically, they can sense low O2 levels. Like if you go, say, if you go live up in the mountains, you're very high altitude, less oxygen up there. So you will put out a hormone called erythropoietin, and it's okay. You can abbreviate that EPO, and that's going to stimulate erythrocyte production so that you'll have more um, red blood cells and more hemoglobin available to carry oxygen. So, removal of waste from the body, the urinary system maintains homeostasis of the blood concentration, volume, pressure, pH, removes toxins, it helps with all of these functions. The functional unit of the kidney is the nephron. It's about 1.25 million nephrons per kidney. And so the nephron is the functional unit, and we'll go over the pieces and parts of that in just a little bit. All right, let's make sure we know the big pieces and parts first. Here's the kidney. Notice why the right one's a little bit lower than the left one. Don't forget you got a liver over here kind of getting in the way, so it's kind of down a little bit. There's the ureter. I'm pronouncing it wrong, so you'll spell it right. Ureter. Ureter. And then here's the bladder. And then there's the urethra. Urethra. So make sure you spell urethra correctly versus ureter correctly. Because say you ended up with a stone, a kidney stone that's stuck in the ureter, totally different than if it's stuck in the urethra. You're going to be writing these things in charts. So you need to make sure you're writing the correct structure. I'm not going to ask you, is it between E12 and L3 level? Just know the right one's generally a little lower than the left one. So, are they retroperitoneal? Remember the peritoneal cavity? Yeah, they're behind that membrane, so they're considered retroperitoneal, and that's consideration in surgery. The renal capsule, that's just the collagen fibers on the surface of the kidney, right? Perirenal fat, I'm not 100% sure that's spelled right there, helps protect the kidneys, and it's just adipose tissue that's around there. And then you have renal fascia. Renal fascia anchors, it anchors the kidney to the back wall, the abdominal wall. Okay, so it's easier if you can see this. So here we are in a horizontal section. So here's a kidney cut across. This dark pink area is the medulla, and this lighter orangey looking area is the cortex, and that collagen capsule on the outside is the capsule. So here's fascia holding it in place. Here's perirenal fat, kind of protecting it. Okay. And we did those structures. See everything with a box. The renal cortex is a superficial region. Don't confuse that with the capsule. The capsule is the connective tissue outside of that. The renal medulla is a deeper region, and there's subdivisions in here. See the way that's shaped like a pyramid, kind of like a triangle? It's called a renal pyramid, renal pyramid, renal pyramid. In between, they call these columns, renal columns. That's just point and name structures there. But all of this area right here is considered the medulla. Remember, medulla is towards the middle. I'm not going to ask you numbers like this, but almost 5 liters of blood leaves the heart per minute in a normal, healthy adult. About 1,200 milliliters of blood flows through the kidneys per minute. So that's a pretty good bit of your total flow when you think about it. The liver and kidneys receive about half of the blood that leaves off of that descending aorta. So, okay, I'm not going to do a tracing, but we will learn some of these vessels in a little bit. So let's go back to the nephron, the functional unit of the kidney. 1.25 million nephrons per kidney. The urine is formed in the nephrons. The blood is filtered to remove waste, toxins, and sometimes ions inside of the nephrons. Glomerulus. This makes a lot more sense if you can see it. All right. See this little bow of capillaries inside of here? That's a glomerulus. This is just part of your nephron, right? This is a Bowman's capsule right here. It's just simple squamous epithelium, making a sphere around this glomerulus. Let's see if we can see this in a better view here. All right, so this is what we're looking at. So this is the Bowman's capsule, and inside of it, if you cut across, this would be the glomerulus. So just so you don't get confused, the glomerulus plus the Bowman's capsule together, they call that a renal corpuscle. Okay, so see the way you got little afferent arteriole bringing blood in to these capillaries that are inside of here, and an efferent arteriole bringing blood out. Yeah, so that's kind of part of your, I guess you could say that's part of your nephron also. Now, what they're not showing, well, I'll come back to that. This tubule right here, see the way it's all curled up, it's convoluted, and it's close to the renal corpuscle here. So that's the proximal convoluted tubule. And then this loop is named by somebody with the name of Henle, loop of Henle. They're trying to just call it a nephron loop now. I don't care, either one. I like loop of Henle, right? Henle. And this anatomy, so we're not going to need to know there's a thick and a thin descending loop and a thick, thin, and a thick ascending, part of this loop. Just the whole thing, loop of Henle. This is the, distal convoluted tubule. This little piece, I'm not too crazy, I probably won't point at that, but it's called the connecting tubule. So a connecting tubule is just that little piece from this distal convoluted tubule to the collecting duct. Now, this is out of an older edition of your book, so they changed connecting tubule to collecting tubule, mainly because the students just kept calling it collecting tubule and everybody gave up, right? So now that's the collecting tubule, that's the collecting duct. Okay, so that's your main parts of your nephron, right? So if I just said, name 6 major parts of the nephron, you could go renal corpuscle, proximal convoluted tubule, loop of Henle, distal convoluted tubule, connecting or collecting tubule, and collecting duct. Now that's going to flow into something down here called a minor calyx. We'll get to that later. If you wanted to, you could add in your afferent, your efferent arteriole, and what we did not draw, this is going to go into a bunch of capillaries, and these capillaries are going to wrap all around all of this nephron right here, and we'll talk about why that is. later. Okay, so these capillaries that are inside, that are part of this glomerulus, they're really leaky. That's their job, is to filter. This is filtration that goes on inside of here, inside of this Bowman's capsule. And the filtrate is caught in this space. Okay. And then that filtrate flows, you can see the little arrow, into the proximal convoluted tubule, and it's going down the nephron. You can follow the arrows, right? So there are four major functions of a nephron. So one is filtration. That's what's going on here. This is real leaky. These are what they call fenestrated capillaries. See if I got a picture. Somewhere I do. Where did it go? Anyway, they have little pores, little holes. They're very leaky. There you go. So fenestrated capillaries, and this is your glomerulus, right? Then there'll be a basement membrane out. They're connected to a basement membrane, and then you have these cells wrapped around. They're called podocytes. Podo means foot, right? So they have these little feet. See the little feet? Those are called pedicles. And the little slits in between the feet, they call filtration slits. So all of this, the filtrate has to get across the capillary, the basement membrane, and through these slits. And so before it is in this space here, and it's called filtrate, right? Now, that filtrate is going to have stuff in it, but it should not have red blood cells in it. They should stay inside of your capillaries. You still have plenty of plasma inside of here. It's not like all of your plasma and everything goes out and becomes filtrate. Just a portion of it. I forget the exact number, maybe, I don't know, 40%. And so it has stuff in it. And some of that stuff you might want back. Think about it. Glucose. Is glucose going to be in this filtrate because it dissolves in that liquid? Yeah. Well, you're going to need to get that glucose back. So remember the four functions. Filtration is one of them. Now, reabsorption. That's another one. So see these capillaries, the way they're wrapped all around your nephron? So you can transport the glucose from inside of here back into these capillaries. This is called a peritubular capillary network, right? So that's reabsorption because you're taking your glucose or whatever, it could just be the water back into the bloodstream. So that's reabsorption. So that's the second function of a nephron. Third function is secretion. So secretion, let's think about that a little bit. Say you took a medicine like penicillin, and a lot of it got filtered in your renal corpuscles there. But some is still coming out. This efferent arteriole still has some penicillin in it. Your body might say, I don't really like this molecule. I want to get rid of more of it. And you can secrete. There's like little transporters. We're not going into all this mechanism, but you can secrete say that penicillin into this nephron tube right here, this tubule. And so you're getting rid of even more of the penicillin. It's not just in your filtrate, it's being secreted into what's going to become your urine, right? So that's secretion. And then as this gets more and more concentrated, becomes urine, then it goes out, it leaves out the minor calyx through this collecting duct here, and then that would be excretion. So that's your four main functions: filtration, reabsorption, could be reabsorption of whatever, ions or water or glucose, reabsorption, then it could be secretion, like we just talked about, and then of course excretion, because you're getting rid of waste. Okay. And in physiology, you'll learn how that happens. Where is the water reabsorbed? Where is sodium, you know, reabsorbed or excreted or whatever. Um, all right, or secreted, I guess I should say. We didn't give you vasa recta, but just remember that. See the way I got that down? See this vessel going all down the length of this loop? Remember that term for when you get to physiology. They're going to talk about that. Okay. Let's see if we skipped anything. No, this is just talking about your little fenestrated capillaries. They're leaky, right? More leaky than the regular old continuous capillaries, but not as leaky as the ones we haven't talked about yet, which are sinusoidal capillaries. Sinusoidal would be in the liver and the spleen. They're really leaky there. Okay. All right. So don't forget your podocytes. They look like little fried eggs with feet on them. See? And then the little feet are pedicles, and the slits in between are filtration slits. All right, so there's our major parts of our nephron. Now, in physiology, you're going to learn what's secreted where, what's reabsorbed where, all of that kind of stuff. That's what I like about anatomy. It's kind of easy compared to that. Okay, I think we're good there. I think we're good there. So don't forget, there's 1.25 million of these nephrons, right? So they drew it kind of big. But if you made a microscope slide and say you cut across here, and you cut across that renal corpuscle, it's going to look like a little meatball inside. And then you're going to barely be able to see the simple squamous Bowman's capsule around it. And there'll be a little space in between, and that's where the filtrate, is caught. So it's going to be a lot of these. So you made a slide and it cut across, this section. If you see the meatballs, the glomeruli, that's plural, glomerulus is singular, then automatically you're looking at the cortex of the kidney. See the cortex up here? And this is a renal pyramid down here, so that's medulla. The loops of Henle loop down into the medulla. Some don't loop very far, some loop pretty darn far. We're not going to get into all that. But they loop down in there, and there's a reason for that, and that's because there's different osmolarities, down in here, and that helps it do its function, and you'll learn about that in, your other courses. So that helps, the nephron to concentrate the urine and then excrete it. So notice the way your distal convoluted tubule comes over real close. See, they always draw it like this. Don't get confused. See the way the proximal convoluted tubule is stretched out from the distal convoluted tubule? Well, in real life, this distal one comes over here real close. It crosses back around. So this is drawn more normally, but it's just showing you that that comes really close to this area. And so there's communication going on here. And basically it's kind of like, we need to filter more or we need to filter less. There's communication going on between these structures. And we don't go into all that. That's for another course. So, okay, just see the way they're positioned. So if you made a slide and you cut across the medulla, you're not going to see any meatballs because don't call them meatballs. You won't even get a half point. So these glomeruli, they're going to always be in the cortex. Now the loops of Henle's and the collecting ducts and all of that, that's down in the medulla. So if you cut across here, you're going to just see a bunch of little circles or oblong looking circles, depends on how it's cut. And it could be little simple squamous ones, or it could be kind of simple cuboidal ones or whatever. And that lets you know that you're in the medulla. When you see the meatballs or the glomeruli, you're in the cortex. And I'll put some slides of that up for you. All right, so there you go. There's a cortical nephron, they call it that. It doesn't loop that deep down into the medulla, and then the juxtamedullary nephrons loop way down. I'm not going to hit you with those two terms. Maybe another course. Just know that the loops of Henle loop into the medulla. That's all I'm trying to show you here. I think most of your nephrons are like this. Okay. So it's a tongue twister. It's the glomerular apparatus. The nice thing is, on the test, you can just call it the JG. That's fine. Everyone calls it the JG. It releases factors, one enzyme and one hormone. And by the way, we spelled this enzyme wrong. Take one of those N's away. It's just renin, R-E-N-I-N. There is a hormone called renin, but it's something totally different. It has nothing to do with this. So I think that's what happened. But no, just go renin. Just know it's an enzyme and it leads to reduced urine volume. We're not going to go into all how that happens. Like in physiology, they're going to talk about renin, angiotensin 1, angiotensin 2, aldosterone, and then, how that affects your water or your urine volume. We're not doing it. Just know that renin is put out by the JG, and it's an enzyme. It leads to reduced urine volume. Erythropoietin, you don't have to spell it out. Just go EPO. It's a hormone, and it stimulates production of erythrocytes. So they also give that to cancer patients after chemotherapy to try to keep their blood count up. And this is the one you may have heard of EPO a while back. A lot of the bicyclists, they were worried that they were using EPO, uh, to increase their blood volume, and they caught quite a few of them doing it. I think it's technically that's not true blood doping. True blood doping, I think, is where you take like a pint of your own blood out, you store it, then you exercise and work out, and then a few weeks later, a month later, whatever, you put your own blood back in. That's harder to catch, although they can catch that, and it's not a good thing to do. It's tough on your system, I understand, but they can catch that too. But EPO, if they were put, especially if it was a synthetic one they were putting in there, they could catch it and they could tell if somebody had, quote, doped with it, unquote. Um, so anyway, you can do this naturally and it's not cheating. You just go live up in the mountains, up in Colorado or wherever, and you're going to put out your natural EPO. So that's why all of our training camps for the Olympics and all, they're pretty much at high altitude because they know it's going to make the athletes produce EPO, and then it's going to they're going to have the ability to carry more oxygen. Okay. Okay, where are we? Okay, that's just your distal convoluted tubule. Don't get confused. It came over close. That's your JG complex. Okay, so this is what's making renin and EPO. So here comes an afferent arteriole. See the blood's coming in, and then filtration's happening in here, and then blood's coming out. Okay, so that's an efferent arteriole. All righty. Notice the way you got little muscle around your arterioles. And so it's kind of weird to have an arteriole on either side, but that gives you more control of your filtration, right? Because your system can either constrict or dilate these vessels on either side and affect that filtration. I'm not going to give you a tracing, so don't worry about that. Blood doping, we talked about a little bit. And like I said, true blood doping, you're actually using your own blood, not EPO. But they've kind of lumped it all together, and they call anything like EPO, they call that blood doping too. Now, um, there's our biggies. Filtration is what's going on inside the Bowman's capsule. Secretion, I would make a little note here. Put peritubular capillaries, because the students were getting confused. They were going, well, the glomerulus is capillaries. Yeah, that's true. So this is written poorly. So secretion would be peritubular capillaries to the nephron. Reabsorption, and that's spelled wrong, that should be a P. Reabsorption is from the nephron into the peritubular capillaries. And excretion, we talked about going from the nephron out the minor calyx. Well, let's figure out what a minor calyx is, as long as I got you here. That's a minor calyx. This big one is a major calyx, major calyx, major calyx, minor calyx, minor calyx. Calyces is plural, like these are minor calyces. This is a renal pelvis, rhymes with Elvis, and this is a ureter, okay? So those collecting ducts are flowing into these minor calyces, okay? And so that's pretty much, that's urine at this point, and then it goes on down to the bladder, okay? Then from the bladder, it goes on out, right? The sinus would just be the space. If you took all this out, you see where this is back here? That's in the renal sinus. No way I can point at it. A renal hilus, it's just where all of the vessels and all of this goes into it. No way to point at that. See hilus over here. I know it's on your study guide, but I don't have a good way of pointing at it. So here you can see cortex. You can see pyramid. Okay? So let's back up and down. Okay. So kidney failure is when your kidneys no longer, there should be a G there, function to remove toxins from the blood. Uremia is toxicity of the blood. That could be a bonus question, maybe. Dialysis is a machine that does the function of the kidneys. And so they have these dialysis units, right? And so, usually I think about 3 times a week or 3 or 4 times a week, they have to go and run their blood through these machines and let it, you know, detoxify it, and basically do the job of the kidneys. And so it's pretty tough on them. And so that's why there's a waiting list for kidney transplants. There is another type of dialysis. We're not going to go into it, where they can use the peritoneal membrane and they run it through there in your peritoneal cavity, and that's actually kind of easier on them because they can do that while they're asleep. But everyone's not a candidate for that, having a shunt put in, to their body wall like that. Having only one kidney is good enough. So can you live without both kidneys? Can you live with just one kidney just fine? Yeah, 2 are better, but 1's fine. Usually, as long as it's functioning properly. I had a student one time, he showed me his x-rays. He actually had a 3rd kidney. I don't know how good his filtration was, probably pretty good. But it wasn't quite full size, but they had done tests on it, with the dyes and everything, and it was functional. Yeah, it was kind of cool. ADH, antidiuretic hormone. So that's produced in the hypothalamus, and it's released from the posterior pituitary. So make sure you study your hormones, the ones that are made in the anterior pituitary and the ones that are from the posterior pituitary. They're not made in the posterior, they're just released in there. ADH and oxytocin are the 2 that are released from the posterior pituitary. Right? And antidiuretic hormone basically has an effect on the collecting ducts, and so it'll cause these cells to reabsorb water. And so a diuretic is going to make you go to the bathroom. So an antidiuretic is going to make you not go as much. Got it? But now, say you drink alcohol, that can inhibit the release of ADH. It's going to make you go to the bathroom more. Okay, so that can inhibit the release. So that's why it's not a good idea, if you're out in the heat, at the beach or whatever. You can't drink alcohol to rehydrate if you've been sweating, because it's going to actually cause you to lose more water, and you can get in trouble pretty quick that way. All right, did that. Make sure you know the parts. Did those. Make sure you know the parts. The ureter, about a foot long. They go into the posterior side of the bladder through these little slit-like orifices, and they actually have transitional epithelium inside of them, just like the bladder has transitional epithelium. I can go, true or false? The bladder has transitional epithelium. You'd go, true. What about the ureter? True. So it looks It almost looks like stratified cuboidal, but then when it's stretched, say your bladder is full, it'll look more like stratified squamous. So that's why it's called transitional, because it transitions from one look to another. There's a muscle around there, bladder there, and it can, well, right now we're talking about the ureter, so there's muscle around there too, and it can kind of cause peristaltic type contractions, to move the urine down. The bladder has a detrusor muscle that's 3 layers of muscle actually around the bladder, smooth muscle. The trigone's easier when you can see it. So here's the detrusor, right? This is the trigone. It looks like a triangle. See, here's where your ureters are coming in. So this is a window cut out of the front of the bladder, and here's your ureters, and they're coming in down here on the posterior side. So if I just put a piece of tape here, you'd go trigone. What is this muscle? 3-layered muscle. You go detrusor. True or false? The bladder has rugae in it, just like the stomach has rugae in it. True. This is a prostate gland. We'll talk about that more when we get to reproductive. So this is a male because it's prostate. They got a little wedge cut out of it, and they're showing you the prostatic urethra right here. That's just a part of the urethra. And then this would be the membranous urethra. And going on out the penis would be the spongy or the penile urethra. It's all urethra. And then you have a little sphincter here called the internal urethral sphincter. And then this would be the external urethral sphincter down here. Which one can you control and hold? Say you got to go to the bathroom, but you're holding it. You're controlling this external sphincter. So that's under voluntary control. This one's not. Okay, this under sympathetic control. All right, so I think we're good there. This female, right? Notice no prostate, but you still have internal sphincter and external sphincters, right here, and still got the detrusor muscle and all that. So don't confuse the urethra on a sagittal section like this with the vagina. See, this is the uterus. We'll get to all that on reproductive. So that's the vagina right there. This is coming out of the bladder, so that's the urethra. Okay? And this is just showing you that the bladder, when you're pregnant, can get pressed down on. And so a lot of times pregnant women complain they got to go to the bathroom a lot because of this. So this is just male again. So that's the prostatic urethra, membranous urethra, spongy or penile urethra. It's all urethra. Okay? And then there's the bladder. Okay, and you can see the ureter coming in behind here. And then we'll talk about the reproductive stuff later, another lecture. This just showing you if you collected every bit of filtrate all day long and you could somehow rehydrate, you make 180 liters are filtered a day. That's how much filtrate basically is made. How much of that do you get back through reabsorption? Remember reabsorption? 99%. So if you do the math, approximately 1.8 liters are excreted per day. So that if you just measured how much urine you produced in a day, it's generally around 1.8 liters. So that's kind of important. Kind of remember that, because say you have a patient, they've got a catheter in, you need to monitor that and make sure they're producing the correct amount of urine during a 24-hour period. Now, if you did not have antidiuretic hormone, they'll make way too much, maybe 6 times that amount, right? So that's actually a form of diabetes, even though it has nothing to do with sugar, right? They call it diabetes insipidus. And they do have medicines that they can treat that with. Well, I'm not going to ask you how much sodium you reabsorb, but look, it's a lot. Glucose, I could ask you. In a healthy person, say you got 1 gram per liter of glucose in your blood, basically. That would be 100 milligrams per deciliter. That's usually the way they measure it. How much of that is resorbed? 100% in a healthy person. Now, if you're diabetic and your blood sugar gets way high, you're not going to be able to reabsorb it all. So, because little transporters control this, and they can only go so fast. And then once you max them out, you're going to start spilling glucose into your urine. And so that's how they can tell, uh-oh, diabetes. They have those little, they call them multi-sticks. You can get them at the pharmacy. I don't think they're prescription. And you can test your urine with that and see if you have sugar in your urine, okay? Because they'll change color. And then urea, you'll learn about that in physiology. We're not going to even go into that, but some of that is resorbed. Okay, so don't forget your pieces and parts. Okay, now let's look at the blood vessels. Here's the renal artery. Then it branches in these big old segmentals. I'm not going to even worry about those, but go ahead and look at these interlobar. So I think of the pyramids as lobes. So the ones in between were interlobar. Going across the top of the pyramid would be an arcuate, arc, like making an arc, arcuate artery going across there, and then they're going to flow into these little interlobulars. And of course, that's going to go into your afferent arteriole and then do the whole 9 yards, you know, in and around the nephron, and then it's going to flow back down this interlobular vein, arcuate vein, interlobar vein, and then you're going to end up in the renal vein and go back to your and go to the vena cava, inferior vena cava. So it's just point and name. If I say, what's this red guy? And here you go, interlobar artery. What's the blue guy? Interlobar vein. What's this guy arcing across the top of the pyramid in red? Arcuate artery, interlobular artery, interlobular vein. So make sure you can point those out. So let's look a little closer so you can see the little afferents coming off of here, going into the glomeruli. And they didn't draw the peritubular capillary network, but it's around here, and that's going to flow back into the venules and then down this way. Okay. So I think we're good. All right. So I'm going to go stop share and see about putting this up for you. All right. Stop share. And